Firstly, I'd like to extend our warm welcome to Associate Professor Carol Whelan.
Thanks very much for that warm welcome. It's an absolute pleasure to be here in Sydney. The sun is shining, so thank you very much for the invitation. I'm going to be talking about ATTR amyloidosis. So when I think about how I look after my patients with ATTR amyloidosis, I have to make sure that I have the right diagnosis. So there are two types of amyloid that typically will affect the heart. ATTR, which is what I'm going to talk about, which can be divided into acquired or wild type ATTR. It used to be called senile. Not such a good term. I know that patients prefer to be wild than senile. And also hereditary ATTR, which is less common. There are lots of different variants that can be amyloidogenic, which can cause amyloid to develop. And also there is AL amyloidosis, which my colleague Strathis is going to talk about, so I'm not going to touch on that. So what is the size of the problem here in Australia? Well, there was a bone scan study in Brisbane looking at patients who are having a bone scan for lots of different reasons and seeing how many of those patients had their heart light up to suggest that they had amyloid in their heart. These were individuals over the age of 65. Over 1% of males had evidence of cardiac uptake. Less so in females, but when the older patients over the age of 85 were looked at, then 6% of males and nearly 2% of females had evidence of cardiac uptake on their bone scans. So if we think about the Australian population over the age of 65 being around 2.1 million, then that suggests that over 33,000 Australians may have ATTR cardiomyopathy. So this is a big problem, a potentially increasing problem, and something that we need to be, as clinicians, more aware of. Just to say that this has also been looked at in Europe, and these figures are very similar to the figures that we've found there. So looking at this, I've talked a bit about bone scintigraphy and the prevalence of uptake, but when we look at other studies for other reasons than amyloidosis, we can see that this is almost hiding in plain sight. So HFpEF is a term we use for heart failure with preserved ejection fraction. What that means is the ejection fraction is the amount of blood that is expelled by the heart every time it contracts to get the blood around the body. And so if someone has HFpEF, it means their ejection fraction is normal, but their heart doesn't relax as well as it should. And in that study, 12% were found to have amyloidosis, not just HFpEF. HFrEF is another term we use where there's reduced ejection fraction, so the heart's not pumping as well as it should be and not relaxing as well as it should be. And in that study, 10% were found to have amyloidosis. Amyloidosis can cause problems with the heart rhythm, and so in a study looking at conduction disorders of heart rhythm, again, patients were found to have amyloidosis. Hypertrophic cardiomyopathy is another cause of increased wall thickening in the heart, and it was thought to be separate to amyloidosis, but now we're finding that some patients may have both. Aortic stenosis is a condition where the valve, which is the main outlet valve from the heart, gets thickened and calcified as patients get older. And again, we're discovering that patients may have aortic stenosis, but they also may have evidence of amyloidosis. And lastly, carpal tunnel syndrome is quite a common syndrome, and patients require surgery for it commonly. And we have found, certainly in this study, that 7% of people had evidence of amyloidosis. And we found recently in the UK, looking at patients who'd had surgery for the carpal tunnel, that the of the 500 patients that we looked at their biopsies from their carpal tunnel at the time of surgery, that 40% of them had evidence of TTR or transthyretin amyloid in their wrist. And of those, 25% were then found to have evidence of heart amyloid. So this is something that, as I say, we're increasingly aware of. So how do we go about diagnosing ATTR amyloidosis? This is a still of a heart scan, an echocardiogram, which I'm sure many of you will have had. You lie on the couch on your side, there's gel, and an ultrasound is taken. And so here we have what looks very typical for someone who has amyloid affecting their heart. The heart muscle is thickened. The atria, which are the filling chambers, are bigger than they should be, and the wall between the atria is more thickened than it should be. And these are the valves, and they're also thickened. These are moving pictures of the heart, and what I would like to draw your attention to, everything's upside down. So this is the main pumping chamber, the left ventricle, and at this part of it, it's pumping quite well. We can see it's coming in and contracting. Whereas at this part of the heart, what we call the base of the heart, then the contraction isn't as good. And this, what we call longitudinal function, this movement is almost absent. The ejection fraction measures that contraction, but the longitudinal contraction is impaired. The reason I'm going into this is because we can use this information to measure something called strain, where we look to see how much the heart's contracting at different parts of the heart. And the strain here is normal, where all the parts of the left ventricle are contracting the same amount, whereas in the amyloid heart, the apex is preserved, but at the base of the heart, the function isn't as good, which gives us this bullseye appearance on the heart scan. This is very easy to measure. It's very trackable, so we can look to see whether the heart's getting worse or the heart's getting better. And amyloidosis is the only condition that gives this appearance. Some of you may have also had a cardiac MRI looking at your heart, and we have found this to be really helpful in not only seeing the characteristic features of amyloidosis in the heart, but allowing us to track the burden that is there. And so by using this, this signal, the extracellular volume, which is an amount of the amyloid burden within the heart. It's not in the muscle fibre itself, but in the space next to it. In a normal heart, it's around 27%, whereas in the amyloid heart, in this example, 52% of the heart was taken up by amyloid. So we can use that ECV to see if the heart's getting better with treatment, or indeed if the ECV is getting worse with treatment. And we can use this in AL and ATTR amyloidosis. The DPD scan is what we use in the UK. There are other bone tracers, PYP and HDP, and they all are looking at the bone, and that's what they've been purposed for, but they've been repurposed to look at the heart, because what we've found is that if there's amyloid in the heart, then it shows up on these bone scans. The bone scan is easy to read. If there's no uptake, it's grade 0. If the uptake is less than bone, it's grade 1. If it's the same as bone, it's grade 2. And if it's more than bone, it's grade 3. If you have ATTR or transthyretin amyloidosis, then 99.9% of patients will have a positive DPD scan. We would prefer if it was only TTR where the uptake was seen, but unfortunately it's also seen in AL amyloidosis, so we can't use this scan to differentiate between the two types. So around 50% of patients with AL amyloidosis also will have a positive scan. We know that there are red flags that we can look for to raise suspicion of amyloidosis, and one of those, which is earliest seen is the carpal tunnel, which I've already talked about, and that can appear years and years before there's any evidence of heart involvement. Other things that we might look for are erectile dysfunction, problems with the eyes, peripheral neuropathy with tingling or pins and needles in the fingers and toes. And then we start to see heart problems that might be with the heart rhythm or the pumping action of the heart. So these red flags is what we're trying to raise an awareness of so that clinicians can see that perhaps a patient might have had carpal tunnel surgery, or they might have had lumbar spinal stenosis, or they might have had a biceps tendon rupture. And putting that together, that they then, with a thickened heart, might think, well, this could be amyloidosis. So we want to really encourage people to think of these red flags so that we can make the diagnosis earlier. We know that with the treatments that we have, the earlier the diagnosis, the better the treatments work. So what can you do as patients to help with your heart failure? Well, it's all about diet and diuretics and daily weights. So we want to watch how much fluid we take in. So that's all fluid, tea, coffee, soup, yogurt, anything that has water in it, and aiming for 1.5 to 2 litres a day. If you're drinking more than that, then the diuretics, the water tablets, are having to work harder to get rid of the extra fluid. Want to watch salt intake. We know that food can taste very bland without salt, but a lot of food has already got salt included, so we don't really want to be adding extra salt because if we're retaining fluid, we can retain salt as well. So it's just something to be aware of. Exercise is really important. One thing you can do if you have a smartphone is look at your daily steps, and I've been looking at my daily steps since I've been in Australia, and I'm doing quite well with all my walks around the botanic gardens of the different cities that we've visited. I plan to go to the Sydney one tomorrow. So looking at your daily steps is a good way, giving yourself a target of how much you're going to walk. And weighing yourself regularly. If the weight is creeping up and you're feeling more breathless and you're noticing that perhaps your shoes are getting a bit harder to put on, there's some fluid in your feet or your ankles, then that's the time to think, well, maybe I need to increase my water tablet, whether it's furosemide or bumetanide, just to get that back on track, perhaps cutting back a little bit on my fluid intake so that I can take control. I can be in charge of my body and make sure that it's back on track, because as things slip and they get worse, then they're harder to then get back on track and back in control. So you can, with your doctors, have that degree of control. Low blood pressure can be a problem, and it can be quite disabling when patients stand up and they feel very lightheaded. Sometimes they may even faint and they can hit their head, and if they're on blood thinners, then that can be quite serious. So something to be aware of if you've been sitting for a long period of time, just to take it slowly. Don't go to set off before you feel that you're feeling okay. And so lightheadedness, syncope, where someone actually faints, can be quite common. Another thing that can, the symptom that can be seen is having coat hanger pain, which is when there's pain across the back of the shoulders due to low blood pressure. Or you may just feel generally weak. When's this likely to happen? When there's been a period of inactivity, so in the morning, about when you're about to get up, or perhaps when you have to get up in the middle of the night to go to the toilet, after exercise, on a hot day, after standing for a long period of time, straining whilst going to the toilet, or if you're ill for another reason. And also blood pressure drugs. You may have been diagnosed with high blood pressure in the past, but actually with the amyloidosis diagnosis, those blood pressure tablets may no longer be required. And so it's something to look at with your doctor. What can we do about it? Well, the late Queen was very good because she stood a lot when she was the trooping of the colour and all the different ceremonies, that she would be standing for a long period of time. So the late Queen Elizabeth would just go very subtly up onto her tiptoes, and you don't really notice that she was doing it. And that gives the calf muscles the blood, to get the blood back to the heart. So something just to look out for. Another strategy is to perhaps pretend you're tying your shoelace, even if you haven't got laces in your shoe. So that's crouching over, again helps the blood to get back to the heart and to stop the fainting from happening. So things to look out for. I've talked about furosemide. It's the mainstay of the diuretic. Sometimes we switch to bumetanide. Other drugs that we will use are spironolactone and eplerenone, and they work very well with furosemide or bumetanide. And more recently, we've been using SGLT2 inhibitors, dapagliflozin or empagliflozin. They were first developed for diabetes because they help to get rid of water and they help to get rid of sugar in the urine. But we found that they're very helpful in the amyloid cardiomyopathy, amyloid heart. They don't typically affect the blood pressure too much, and they can also help along with the diuretics to get rid of extra fluid. So one to look out for. We do like to monitor the kidney function when you're on these sorts of drugs, and also we can use the NT-proBNP, which is a marker of the amount of strain that the heart is under, to track your progress. So this was a retrospective study, so we look back in time, looking at patients attending our centre in London and seeing what conventional heart failure drugs they were taking and see whether they would be of benefit with amyloid cardiomyopathy. And what we found is that patients who had impaired heart function benefited from being on beta blockers. Patients across the range of the ejection fraction, HFpEF, HFrEF, benefited from being on the MRAs, so mineralocorticoid receptor antagonists, spironolactone, eplerenone. But patients benefited least from ACE inhibitors, so things like ramipril, perindopril, or ARBs, so things like losartan or candesartan, just because they can reduce the blood pressure, and if the blood pressure is already low, that can make matters worse. Of course, this is just a guide, so there may be some of you who are on some of these drugs and not on others. So it is often having that conversation with the individual and just making sure that we've got the right drugs for you. And then this was our study looking at SGLT2 inhibitors, which I've just discussed, and we found that patients were living longer if they were on these drugs, and they were also being hospitalised less for heart failure, which is a great thing because often when someone is admitted to hospital with heart failure, then they can be in hospital for several days. So if we can keep people out of hospital, improve their quality of life, that can only be a good thing. Other symptoms that we look out for, particularly if someone has hereditary ATTR amyloidosis, they may have diarrhea, they may have alternating diarrhea and constipation, which can be challenging to treat. We often will use a combination of loperamide and codeine. Peripheral neuropathy can also be a feature, and so we may use different creams for that. Or indeed using things like amitriptyline or gabapentin or pregabalin for the neuropathy. Communication is really important. The symptoms can be from different systems in the body, so you may have different doctors involved, different nurses involved, and so communication between the patients and the team is really important. And it's also important to have written information, because a lot of information may be taken in at the time of the consultation, so it's a lot to take in. And it's also quite a good idea just to jot down some questions during, before you're going to the consult, so that you remember what you want to ask, and taking along a family member so that you can remember more of what was discussed. There has been a huge explosion of interest in ATTR amyloidosis in the last few years, which is fantastic. And with that interest, there have been lots of different drugs in development or have been developed and they're already available. So for ATTR cardiomyopathy, we have tafamidis available, which is a TTR stabilizer. So it stabilizes the structure of the protein which is produced in the liver. And that is given orally once a day. And that is available here in Australia as well as in the UK. Other stabilizers, diflunisal, which is used less commonly, and acoramidis, which is a newer TTR stabilizer, which isn't yet available, but it looks to be, certainly in vitro, to be a more of a stabilizer than tafamidis, and so one to look out for once available. So they stabilize the protein. We can also look to reduce the amount of protein that is produced in the liver. And all these different drugs do that in a slightly different way. Patisiran and inotersen were first shown to reduce the amount of TTR production. And then we have now vutrisiran and eplontersen, which are the second generation drugs. They're given by subcutaneous injection. And then the new kid on the block is one called nucresiran, which is a third generation, and it looks like it may only have to be given by subcutaneous injection, maybe every 6 months or even on a yearly basis. It is being looked at in healthy volunteers currently, and it will then go into a study looking at patients with TTR cardiomyopathy at some point soon. Gene editing is also used to edit the actual TTR gene to reduce the amount of TTR that is produced. And then lastly, Alexion is an anti-TTR antibody, a monoclonal antibody, which reduces the amount of amyloid that's already there, so reducing the deposits. So there's a lot going on. This was the ATTR trial looking at tafamidis, where tafamidis was compared in 2 doses against placebo and was found to reduce all-cause mortality by 30% compared to placebo. And patients deteriorated much less quickly, which we can see from the 6-minute walk test, and also their quality of life was better compared to placebo. But we can reduce the amount of TTR that's produced, but if the TTR is already there in the heart, it would be good to be able to get rid of it and improve on the heart function. So on the left-hand side here, we can see an example of a patient who attended our centre, had been attending for a few years, and my colleague Mariana Fontana was looking at his cardiac MRI. And to her surprise, she could see that the heart function compared to the year before had improved, and in fact from the year before that. So there had been gradual improvement in his heart function. He wasn't in a trial and he wasn't on any treatment because the treatment wasn't available at that time. She then systematically looked at everybody else attending our centre who had had CMR, and to her surprise again, found that 2 other patients, of all the patients that we have attending our centre, also showed that their hearts had improved. And these 3 patients had developed anti-TTR antibodies, so antibodies against the TTR, and they had then managed with these antibodies to reduce the amyloid that was in the heart and improve their heart function. And that continues to be the case. So with that, we know that antibodies against TTR can remove the existing deposits. And this trial has been looking at just that. So we're potentially going from a situation where we want to stabilize what's going on and reverse what's going on with these antibodies. Can we prevent what's going on? And so that's the next holy grail, where we want to potentially prevent patients from developing, hereditary patients from developing amyloidosis. So we know if someone carries the variant, not everybody who carries the variant goes on to develop the disease, but if we can identify those who have family history and know which variant they have, then we may be able to prevent the amyloidosis from developing, and the trial will be called ACT Early with acoramidis, the TTR stabilizer that I mentioned earlier. So there's a lot going on. In conclusion, ATTR cardiomyopathy isn't as rare as we first thought. We now have treatments available and to halt the progression of the disease, and more treatments are likely to be available in the future. Some heart failure medications are of benefit for ATTR cardiomyopathy, and it's really important that you feel that you're managing your disease and being in control, looking at your response to the diuretics. And if there isn't a response from what you're doing, seeking help early so that when things aren't right, that you can get that help before they deteriorate significantly. It is an absolute pleasure to be here in Sydney on this beautiful sunny morning, so thank you very much for your attention.